Hello everyone, my name is Hung Lee. I'm the infectious disease pharmacist at General Haley. Today, my topic is the pharmacokinetics consideration for the antimicrobial therapy in the dialysis. We know that we have many patients that on the hemodialysis and the dosing need to be adjusted. And you know that there's when we have the patient on the hemodialysis, the dosing is kind of different. And we know the patient cannot clear the antibiotic very well. So if we dose with the normal dose, that could be overdose. And if we adjust the dose, we reduce it, how much we should reduce? So that can bring it up to the potential to underdose. Most of antibiotic we have, we actually got the molecular weight is different. So the removal rate for different antibiotics can be different. And some of them is like significantly different. So this talk will discuss about the different type of the dialysis and also the different kind of antibiotic. We have generally we have three different types of hemodialysis. The hemodialysis that usually that you see very often, 3 or 4 times like a week. A peritoneal dialysis, sometimes the patient on the peritoneal dialysis that are mostly for transitional. And in hospital, the renal, within the continuous renal replacement therapy, the CRRT, and there are the 3 different kinds. Either the hemofiltration, hemodialysis, and the hemodiafiltration. These are the different, and the dosing is quite different too, because it depends on how much the material, the substance that we got removed from the blood. Let's look into the hemodialysis. This is the regular one. If you see this, the blood come in from one side and blood come out. And the distillate coming in, but mostly they use the concentration. The difference the concentration from going from the high go to the low concentration. And even with the same hemodialysis, they use a different membrane to filter out the different particles. The top one, you see that it's called the low plug filter. So it has a small hole, mostly to remove the water. The bottom one is the high plug filter. It has a bigger hole. It removes not only the water, but also the other large molecular weight, even something like albumin.
What are the names of those filters again?
The top one is the low flux filter.
Low flux.
The lower one is the bottom one is the high flux filter.
And which one's more common?
Both of them are very common. That depends on how the renal decide when they put it in they put in the order. Depends on the patient condition. And how do you find out whether it's a low flux filter and high flux filter? You can look into the filter spec. You can talk to the renal technician to find out what kind of the filter. But it's easy. You can ask okay, this is the high flux or the low flux filter. They can tell you right away. Some people they said that you can look into the material of the membrane, so you can tell whether it's the low flux or high flux, but not quite. If you see this, this slide shows you that high flux filter and what kind of membrane material that have been using. You see that some of them actually that are using they use the same material. So for the hemodialysis, it depends on how much the solubility of the drug. And remember, the distillate is the aqueous base, so the lipophilic drug that less likely to be in the plasma and mostly in the tissue, whereas the hydrophilic drugs stay in the plasma most of the part and that's when it got removed. How you can tell the drug, whether it's lipophilic or hydrophilic, you can look into the volume distribution. You can open the packet insert, you see that if the high volume distribution is large, then you see that most of them that stay in the tissue. And also, the hemodialysis cannot remove the drug that bind to the proteins. So it remove only the portion that stay, the free portion that in the plasma only. If the drugs have a high portion protein bound, then you don't see that it remove much. How do we find the information? It's going to be in the packet insert. Low flux filters. Low flux filters, there's a couple names. There are many different brands out there. So I just name a few that we use a lot in at our VA. F6, F8, OptiFlux, 16 NR, OptiFlux, 18 NR. Usually with the low flux, the blood flow is about 200 to 350 a minute. The dialysis flow rate kind of 500. And the dialysis section usually lasts about 4 or 5 hours. Sometimes we cut down short to 3 hours, depends on the patient conditions. And with low flux filter, anything with molecular weight less than 1,000 Dalton, it got removed too. It's over 1,000 Dalton. How many drugs that have a molecular weight, when I said drug, it means the antibiotic over the 1,000 Dalton? Not many. The next slide will show you. The high flux filter have a big hole, so it remove not only the water but also the other drugs. And the drugs that have the molecular weight more than the 20,000 Dalton, then it can stay. But so with this hole, with this kind of filter, it removes virtually everything on the antibiotics. So in this case, you always need to use the dose replacement after hemodialysis. This slide shows you this. You see that the vertical bar, it shows this is the 1,000 Dalton. And on the drug on the left side, you see that it has molecular weight less than 1,000 Dalton. Only 4 drugs have molecular weight more than 1,000 Dalton. It's Penicillin, Vancomycin, Sinucid, and Teicoplanin. Not many. Most of them, it doesn't matter.
How about daptomycin?
Yeah, the daptomycin it's not in here, but the daptomycin have a small molecular weight. Now let's talk a little bit about peritoneal dialysis. We are very confusing when we put in an order for the treatment, especially for the peritonitis, whether this is the IP or the IV. And the orders sometimes make a pharmacy confused, because when the physician put in an order for the IV, it's different. The dose is quite different than if you put antibiotic in the fluid to put in for the peritoneal dialysis. So what are the factors that affect the drugs when you give for the peritoneal for the patient with the peritoneal dialysis? Of course, molecular weight, because it uses peritoneal membrane as a filter. So molecular weight, yes, it has a significant effect. Protein binding, volume diffusion, solubility, and the decrease of ionization too. So even the drug has small molecular weight, but it's ionized, so it attached the water molecule around it, it makes it big. So it makes it slow diffuse than the unionized compound. For the peritoneal dialysis, usually the hemodialysis is more effective than peritoneal dialysis in terms of the drug removal. So with the peritoneal dialysis, if even you give IV, you might consider the lower dose than the regular hemodialysis. Like I said, peritoneal dialysis patients, there's always that confusion between the IV dosing and IP dosing. And that it already happened. The dose put it in, people open the book and look into that and look at the IV dosing and put in order for the IP dosing, intraperitoneal dosing, and usually too much. And here's the trick. There's not many data regarding to the peritoneal dialysis dosing. That's a problem. So in that case, you cannot use the IP route, then you have to use the IV route. If the data is not available, then what would you do? Then you want to look into the residual renal functions and go by that. Even the peritoneal dialysis, we have the different kinds. Like one is continuous ambulatory peritoneal dialysis, and one is intermittent. The intermittent is at night. We don't do the dialysis, but during the daytime, we make more frequent. Let's look into get into the details about the peritoneal. The next one is continuous renal replacement therapy. Mostly, this happens in the hospital when the patient coming in, and that's when the renal order. This thing, I don't see it happen. It can be happening at home. So three different kinds: hemofiltration, hemodialysis, and hemodiafiltration. Let's look into each of them. So this is the hemofiltration. It's very simple. It's due to the concentration, the difference. So one is coming from the blood, and one is and then it goes to the filter and coming out there. So the difference between the concentration ingredient coming out. If you see on this left slide, you see the green arrows. When you remove a filter fluid out of the blood, you have to replant it. So there are the two ways, either given pre or post. This slide gives you a little bit more detail. You see that it uses the membrane only, and it doesn't use the dialysis. So it coming out, it go in here and go through the membrane and filter out. Of course, whatever the weight coming out, the volume, we have to replace it either pre or post. For the hemodialysis, it make it. Now we use not using the concentration, we use the pressure. So we use the pressure from the arterial, and it diffuses to the membrane and get out. And they also use the dialysis, the fluid, in order to carry out more efficient the amount of the wet material from the blood. This slide gives you the pictures in more detail. You see that one dialysis coming in and the blood coming in different, two different the opposite directions, and it uses wet material go from from the high concentration to the lower concentration. Hemodiafiltrations. In the past, we see a lot about the hemofiltration, but now so at the VA, I see the renal order a lot about hemodiafiltration. It looks like a more efficient way to remove it. So it's the combination, not only the pressure, but also the concentration. So it removes a lot. And what's the difference between the three? So how much you say hemodialysis, hemodiafiltration, what's the difference? This slide shows you that how much material can be removed, and the decision is from the renal, not from us. From our standpoint, we're concerned about the antibiotic. And if you see over here, we're concerned about like like we mentioned the low flux filters and the high flux filter. The low flux filters we're concerned about the molecular weight less than 1,000 Dalton. With high flux filter, we're concerned about the antibiotic with molecular weight less than 20,000 Dalton. So we don't have anything much indicator over here, but we'll let's look into these two slides. The yellow one is the hemofiltration. You don't see it to remove much, but with the hemodialysis and hemodiafiltration, you see there's a lot of things. The red one and the green one, there's a lot of removal of the material. This means that you will lose a lot of antibiotic. So in terms of the CRRT, what are two factors that we concern the most? Molecular side and also the protein binding drugs. Those things we need to look into that. Why we have to consider these factors? Because when you open the package insert and you open in the literature, you open up the micromedics, right? Not many drug, and sometimes you look in the drug, you don't see any. Oh, I don't see any dosage in there. So how do we decide whether I should dose them more aggressively or a little bit more conservative? So then we have to look into molecular side and protein binding drugs. If it's highly bound, then you know that it's not much removed. If molecular weight kind of big, large, then you don't have to worry much about the removal. Then you can use normal. Most of the time I use the normal dosing. But if molecular weight is kind of low and the protein binding of the drug is kind of low too, it's with continuous removal 24 hours. They run the CVVHD app, for example, 24 hours, it removes a lot. So then you have to increase the dose. Let's look into the drugs. So we have a couple of drugs that either hydrophilic and lipophilic. Remember, hydrophilic drugs stay mostly in the plasma and got removed a lot. Beta-lactam, glycopeptide, aminoglycosides, lipophilic, macrolide, quinolone, tetracycline, rifampin, and azoles. That's why when you see the linezolid in the hemodialysis patient, you still the 612, right? And even with CVHD, you're still using 600 QD because it won't affect much. Let's look into the hydrophilic antibiotics. We look into this. First of all, we talk about the vancomycin. It has the volume distribution kind of low, only 0.7 liter per kilogram. Not much. If the guys with 60 kilogram, you have the volume distribution around 40 to 50, not much. Molecular weight, this is more than 1,000 Dalton. If the renal decided to use the low flux filter, then you give the one dose, but that's going to stay in the system for very long, usually about 4 or 5 days. I know it's hydrophilic, protein binding is low, but because the molecular weight is big, so that's a bit bad. The half-life in the normal patient with normal renal function is only 5 hours, but in hemodialysis patients with the low flux filters can be more than 100 hours. If you see this, the dosing for the low flux filter, usually we give the correct dose at the beginning, and you have to maintain the high level for at least 5 days. And when you know when to redose it, you got a random level on the day 3 or the day 4, and you figure out how much the level dropped, and then you can figure out how long I should how far I should give. With high flux filter, there's a few things that we should consider. Yeah, we still give a loading dose of 15 to 20 milligram per kilogram. Then after that, because they use the high flux filter and remove like a certain amount of the antibiotic, vancomycin, out of system, so we have to replace it with usually with 500 milligram after hemodialysis. But there's a thing that people still have to check the level to ensure that the drop level is therapeutic. And when they check the drop level, they saw that, oh, now it's low. What happened? Most of the time, they didn't do the loading dose properly. They loaded only 10 milligram per kilogram. And then the level is not sufficient in the blood. And after hemolysis, they remove the 500. Yeah, it's always low already. So we have to load it with the proper dose. That's the key part. For the peritoneal dialysis, for the intermittent peritoneal dialysis, this is per exchange. So once daily, so you give like 15 to 30 milligram per kilogram every 5 to 7 days. For the continuous, the dose is different. Within dialysis, 100 milligram per liter, and the maintenance dose is kind of low because it stays in there. Even some of them get absorbed into the system too. For the continuous renal replacement therapy, the loading dose, very standard, 15 to 50 milligram to 20 milligram per kilogram. The maintenance dose is quite different. For the CVVH, only the 500 milligram to 1 time, like Q24, or the 1500 to Q48. But with CVVHD8 and CVVHDF, then the amount, because it uses like the pressure, and especially with CVHDF, the removal rate is higher, so you have to go with the higher dose. So you have to do the replacement is either 1000 to the 1500 milligram Q24 hours. I use the 1500 milligram Q24 hours for the CVVHDF. Of course, we still have to run to draw a level after the third dose. For aminoglycoside, this is the hydrophilic drugs, so it have a low volume distribution because why it stay mostly in the plasma. Molecular weight is kind of small too. Both of them, either amikacin or tobramycin or gent, small, and the protein binding is low or less than 30%. This means that it stay mostly for the free drug stay in the plasma. That's when it was removed. For the hemodialysis, the regular hemodialysis 3 times a week, 1 milligram per kilogram. And we still order a pick and 12 after the third dose. Amikacin is 2/3 of the normal dose after hemodialysis. We still give a loaded dose, but then we have to do the replacement by 2/3 of the normal dose after hemodialysis. And we still have to check and pick and 12. For the for the peritoneal hemodialysis, kind of complicated. There's a difference between the intermittent and continuous. If you want to do the continuous peritoneal, patient have a continuous peritoneal dialysis, then the dose, loading dose, and the maintenance dose are different. And you see that the maintenance dose almost for the continuous peritoneal dialysis, the maintenance dose almost like a half of the loading dose. Now for the continuous renal replacement therapy, it runs at 24 hours. So for the synergy, for tobramycin and gent, you use 1 milligram per kilogram, Q24, Q36 hour. Other indication, you got to move up a little bit, so that 3 milligram per kilogram, and the maintenance dose is kind of low. Amikacin, loading dose lower, 10 milligram. The normal dose is usually 50 milligram, and now for this patient with the continuous renal replacement therapy, only the 10 milligram, and maintenance dose is lower. Of course, we still get pick and 12. Now the carbapenem. Carbapenem is a beta-lactam, so like hydrophilic. It have a low volume distribution. You can stay in plasma mostly, and it have a high clearance, low protein binding. And the same like aminoglycoside. For the hemodialysis, meropenem is 500 milligram Q24, and of course we tend to put in order. We give after hemodialysis. We don't want to give before hemodialysis and then it got dialyzed and not much left in the system. For Primaxins, lower dose 250, ertapenem 500, and you see that it's more like half of the like standard dose, right? What we think it made a big change. Okay. For the interperitoneal route, there's not much information like to give, and most of them, if you could, like if you don't have a data, and most of them they have a similar spectrum, especially between the meropenem and Primaxin. If you don't patient on the meropenem, and the patient is on the intermittent peritoneal dialysis, if you need to switch, then you switch to Primaxin because there's a dose already have established the efficacy for everything, and you can switch it. So that's why we switch back and forth. Unless there's an contraindication, patient have a seizure, then we have no choice. For the continuous renal replacement therapy, meropenem, kind of lower dose than normal, 1 gram Q12, Primaxins, half a dose, normal dose, and ertapenem, we don't have it. So I don't have that, and I looked in the literature, I couldn't find one. This means that if the patient on ertapenem and renal put the patient on the CRRT, then we have to either switch to meropenem or the Primaxin. For the penicillin, they all share the same pharmacokinetic properties, hydrophilic, low volume distribution, high clearance, because and the moderate plasma protein binding. For the penicillin G, 1 million unit Q6, that's low. Napsilin, we don't have the information. I don't have it. For Zocin, kind of low, 2.25 gram Q8, and that's for pneumonia. The other indication usually the lower dose, 2.25 Q12, but then you have to put additional orders, 0.75 gram after hemodialysis. That makes the confused for the nuts. And that's they are the two separate orders, and they got confused. So most of the people, they tend to use a more simple dose, so they use the pneumonia dosing, 2.25 Q8 for everything. But if you want to save for a couple bucks for the hospital, then you use the other one. Well, the nuts doesn't lie much.
That's generic.
For the peritoneal dialysis, not much information regarding to the intermittent peritoneal dialysis. The information mainly for continuous peritoneal dialysis, and this is I got information. This the data I got from the International Renal Association. Well, the screen it looked like it's changing. For the penicillin. For CRRT, it's kind of low for for penicillin G because the short interval, the short half-life. So you see that the dosing is almost similar to the regular dose because all the drug that would have a short half-life, you got to remove it, but then you have to replace it. So it not much change it. Even with the piptazole, you don't see much there's change 3.3.5. 3.375 to 6 hours, it's like a normal dose. Cephalosporine, the same thing. It has the same properties. Cephalosporin. So we do the loading dose and then we do the maintenance dose of 0.5, but some people just keep that 1 gram for every day. They don't change it. That's fine. I do the stewardship. I look into that. I'm still okay. That's fine. No need to change it. Ceftazidime. This is the one that sometimes, like when the patient, you send the patient home, and the patient unable to give for themselves because they don't have an IV asset and have to be given like after hemodialysis session. And if you give the patient with the CPP, the patient have to receive it every day, and if the patient like have only the port for the hemodialysis only, what is the other choice you want to cover for Pseudomonas? Then you switch to ceftazidime because the ceftazidime you give 3 times a week. Say that after hemodialysis, so the patient go to the hemodialysis center, and after that, the patient receive the ceftazidime. The same thing with the ceftriaxone. Ceftriaxone, you have to give the normal dose, and and the timing after hemodialysis. This means that 1 gram Q24. Oh, it's not like you keep the information in here. I don't want to read the number. 3 drugs that we use a lot: cefepime, ceftazidime, and ceftriaxone. Dosing a little bit different. I don't know why it got skewed like that. You see that with the CRRT, the cefepime, ceftazidime, and ceftriaxone, you keep the same. It look like a normal dose. Now let's look into the lipophilic antibiotic. This change is quite different from the normal dose that you usually see. Usually the high volume distributions, and it have like moderate plasma protein binding and low clearance. It stays mostly in the tissue. For the Hemofiltration, hemodialysis, Cipro, kind of lower dose, only 200 Q12 rather than the 400 Q12. Levo, then the dose is almost like a half. Loading dose is 750, but then you keep 500 Q8 with you treat these patients. It looks like the patient have end-stage renal disease. Moxi, I don't have any data for that, but if the patient on the moxifloxacin, then we have to switch to the Levo. In these 3 drugs, we don't have much data. We have only the data for continuous peritoneal dialysis. Why? Because mostly they treat the renal, treat for the gram-negative, for the peritoneal peritonitis, and the loading dose only 50 milligrams put in the bag, and after that the maintenance dose is 25 milligrams per liter. For the CRRT, Cipro, dose is almost the same. Levo, dose is the same, and Moxi, don't see much. It continuous removal, so it works. It's like a good renal, a good kidneys. For linezolid, like it's short. Hemodialysis or CRRT, keep the same dose. Daptomycin, this is a new drug. Not much studies that going on with the intraperitoneal dialysis. So if the patient have peritonitis, then you have no choice to pick the IV drug to give. Make it real quick to the antifungal and antiviral dosing. And usually I look into a few drugs that we use very commonly used. Amphotericin B, hemodialysis. No, with no adjustment, we still dose normally. Intraperitoneal, continuous, very low dose, 1.5. And CRRT that you do 0.4 to 1, depends on the indication, that Q24 hour. With the lipid complex and liposomal, though it be a little bit different because remember the Amphotericin B, the molecule, the drugs, now it capturing either in the lipid layers or in the microsome. It makes it small, a microsphere. So in hemodialysis, you give only the 50% of the normal dose, and in the CRRT, now you see the dose is much higher, 3 to 5 milligram per kilogram. Fluoroquinolones, hemodialysis, only 200 milligram. Intraperitoneal dialysis, 200 per exchange a day. And with the CRRT, if you dose the patient with 200, then you have to boost it up to 400. If you dose the patient with 100 normally, then you have to give 200. It depends on what's your normal dose, your normal dose is. Voriconazole, well, we tend to use the PO only because remember the patient on these patients is like have the problem with the kidney, and the IV have a cyclodextrins, and that's toxic. So the dose is for the PO, not for the IV. Hemodialysis, we use the normal dose, 200 milligram Q12, but CRT, then just still PO, but we still calculate per kilogram. Acyclovir, or like 60% of normal dose for the patient with hemodialysis. For the patient with the peritoneal dialysis, if we don't have any data that how many milligrams of acyclovir we put into the bag for the peritoneal dialysis patient. The only route that we use is the IV 2.5 and the CRT. Like I said, acyclovir have a small molecular weight, so the dose is kind of high, 5 to 10 milligram per kilogram per Q24 hour. And this is my reference. And that's the end. We talk about only the common antibiotic and the fungal, we don't cover for everything. Another question?
I was going to say, it would be great to have some of this talk compressed in sort of a handout that we could have maybe accessible on our, S drive or somewhere so that we could, or at least some summary. Is there any kind of reference source like that that's available?
Yeah, we do have it. We have the handout that we make it about 3 years ago. We still have. Julie, do you still have
Would
it?
anybody find that useful?
No, I agree.
Yeah.
You should write a book, but a lot of your lectures are very useful, actually.
Yeah, and the obesity one is good too.
A lot of stuff, we need to refer back to, like intraventricular and stuff like that we rarely use, but if you could go back to
Okay.
that.
We don't have to pull.
Maybe what you could do, Hung, is if you could send that out on the USFID listserv,
Right.
and just so everybody can have another copy, because it's been like you said, it's been a little while. I remember that document, but I don't think I have it handy any longer, so it'd be great to have it.
Okay, so that's good. I'll put on the S drive and send to the Brailer. So.
Any other
Thank
questions?
you.